Okay, so welcome everyone, bienvenue. Our fifth session on improving palliative care through research. This is our second to last session. So thank you everyone for hanging in with us throughout this program. We've been really excited about the kinds of interactions we've been able to have with you all and our guest experts. So just some housekeeping items. Please share your video when possible. Of course, we realize that some of you might have limited bandwidth, but particularly in the breakout sessions, it's really great to see your faces if possible. Please keep your line muted when you're not presenting or asking questions. And then, of course, unmute yourself when you want to speak. If you are on the phone, you can use *6. You can submit any questions that you might have for the speakers for discussion. You can use the chat feature. And then during the session, if you need any technical assistance, you can direct any chats to Vanessa or Samira. As I said, the didactic portion is going to be recorded and shared, so we're recording now. The breakout discussions are not recorded. So anyone who attends at least 5 of the 6 sessions and completes the surveys, the pre-course survey and our evaluation will receive a certificate of completion for the program. So if you have any issues or you can't attend, please feel free to let us know. And with that, I will turn it over to our course director, Dr. Ian Tannick.
Yes, hello everybody, and welcome, bienvenue encore. So today, as Vanessa said, we're going to hear 4 presentations about palliative care, how to do research into it, and through that research, hopefully to improve palliative care in your environment. And we're going to actually start off today with our regional speaker, Dr. Tonya Onyeka from the University of Nigeria. And then we'll follow it with 3 presenters from the United States, Catherine Pollock, Antonia Bennett. Jean Kuttner will go first, Catherine Pollock and Antonia Bennett. So let's not waste more time. You don't want to listen to me. And Tonya, the floor is yours, or the screen is yours, I should say.
Good evening, everyone. Good afternoon, wherever you are. I'm going to be making a presentation. I'd like to say that the research I'm about to discuss was funded by a grant from the Conquer Cancer Foundation of the American Society of Clinical Oncology. The research I'll be talking about is actually this, titled Enhancing Palliative Care in Rural Southeast Nigeria, Use of an App for Symptom Management. My name, once again, is Tonya Onyeka. I am an associate professor of anesthesia, pain medicine, and palliative care at the College of Medicine, University of Nigeria in Southeast Nigeria. The reason why we thought about doing this was that we had a problem in our hands. We saw we had a problem in our hands. Our patients would see us once and they'll be lost to follow up. And I sat with my team and we wondered what we could do about it. We asked questions, you know, we got in touch with them by phone. They had a lot of problems they complained about. The distances between their homes and the hospitals was really far. They had issues with transportation. They had financial difficulties. So some of these things were the things we found out that was like an obstacle to their care, for them to receiving palliative care, for them to come for their outpatient clinic visits. And we said to ourselves, let's try and see if we can do something to kind of eliminate some of the barriers. And that's when we came up with this research. Okay, so and that solution was called, is what we call the EPAC app. And EPAC is simply an acronym for Enhancing Palliative Care. Next. So this is where we're located, that red dot in Nugu in southeast Nigeria. And actually Southeast is made up of 5 states. As you can see to your right, the right of your slide, 5 states make out the site. So we're one state in the Southeast. And my hospital is the largest tertiary healthcare institution in that state. Next slide. So we looked at enrolling adults who had cancers, who were living in the villages that were very distant to us, or just about where we were located, but in the rural areas. We're looking at adults with cancer who were on treatment, who could speak English, or if they were not fluent with English, they had someone in the household who would accompany them on their visits. They had to have a mobile phone or have the ability to use a mobile phone, and have a caregiver who could also use a mobile phone. And they had to have access to a mobile network and electricity. Next. So what we did was actually a 3-arm randomized control trial. The first group, which is the control group, was the usual care. So these are patients that we sought to see them in clinic and give them their monthly appointments for their next monthly visit. The second group, which we call the app group, were the patients who we bought Android phones for. And in the Android phones, we had apps pre-installed into those phones. And we also gave them SIM cards and gave them data to be able to use the apps on those Android phones. And they were expected to complete assessments on their mobile phones twice a day, in addition to visiting us once a month on their pre-scheduled clinic visits. The third group was the phone call group, and they had a nurse dedicated to them who was to make a call to them once a day from a dedicated mobile phone of our unit, especially to follow up on their symptoms, and then to ask them any related questions. And then they also had the monthly pre-scheduled visits. Next. So this is what we call the EPAC app. It was actually a web-based pre-tested device on which we installed on the mobile smartphone. We used an ITEL 1408. And we had pre-tested on 3 patients with cancer who were not part of the final study, and on 3 health caregivers, 2 doctors and a nurse. The app interface is actually the modified version of the Adult Memorial Symptom Assessment, that's the MSAS. And the data that the app collected was stored securely in a remote location that was only accessible to myself, the principal investigator, and the nurse who was in charge of the app group. Next. The assessments, like I mentioned previously, were done twice a day. We told them to do in the morning and then just before they went to bed. And then the nurse that was assigned to the group that had the phone calls made to them also were supposed to remind the patients and their caregivers whenever we did not receive reports from them. And then if there were any issues with our patients, both the patients on the app group and the phone group, the nurses in those groups were to initiate some support and then reach back to myself and the other doctors in the team for further advice where needed. Next. So these are some of the things to do. So in addition to the pre-scheduled monthly visits that we gave all 3 arms, we also had them fill out the APCA POS, the aortic quality of life C30 form, and then the caregiver satisfaction with the palliative care form. And then of course, the caregiver burden scale was also filled out for these patients. We also ensured that during each monthly visit, we did their routine exams and then treated any existing symptoms. Next. For data analysis, we use descriptive statistics, confidence interval to compare, and then chi-square, where a p-value of less than 0.05 was considered statistically significant. We also analyzed the mean scores of all those outcome measures that we were looking at baseline, at the first month, and then at the last month of the study, which was month 3. We did a Hedges G test to look at the differences in the mean score between those scales to examine the effect size. And we also used the Kaplan-Meier survival analysis to examine the time to loss to follow-up. Next. When we looked at our data, we saw that the mean age of the patients were 53.5. They were predominantly female. Most of them had carcinoma of the breast. When we looked at their pre-scheduled monthly visits, the ones that came the more were those in the group A. The group A is the app group, group B is the phone call group, and then group C is the usual care. So we see that in the usual care group, it was just one patient that came, and after that, which was what we had experiencing previously. We noticed there was a decline in symptom reporting by group A by the second month. For that same group, the app group, the most frequently reported symptom was pain and weight loss, and the least reported symptom was nausea, vomiting, and itching. And of course, we lost the patients in the usual care. That's group C. We lost them to follow up after the first month. Next. So these are the outcome measures. Where I would like to talk about was that the pain scores, we found out that for the patients that had the phone call group, they had lower pain scores than the patients in the app group by the first month. But then by the third month, there was a reversal, okay, with the patients in the app group having less pain scores than the patients in the phone call group. For quality of life, using the aortic quality of life C30 questionnaire, we did not observe any significant change across the groups. For farm care, the patients in the app group had more satisfaction with their care. Their caregivers had more satisfaction with their care than the patients in the phone call group at baseline. But by the third month, there was a reversal. For the APCA-POS, both patient and APCA-POS caregiver, the patients in group B, which are the phone call group, were significantly had more higher scores than the patients in the app group. For caregiver burden, we were not able to effectively measure their burden for the caregivers because not many of those patients came with their family members in all visits. Next. So we did the time to loss to follow up, and we can see the graph that we had huge attrition by the third month for all the groups, but it was highest with the usual care group. The mean time to loss to follow up was larger with the patients in the group A, which is the app group, and they also had the longest retention in follow-up. Next. So we concluded by looking at our data that use of a mobile app did not seem to promote increased follow-up visits for this cohort of patients, maybe because they had high attrition rates. But our findings support, previous reports of positive influence of mobile device in improving certain outcome parameters in cancer patients. Next. So some of our limitations were the low study retention rates, the high attrition rate. This is a big limitation. We found out that our patients did not have the ability to renew exhausted data because their finances were poor, and we couldn't help them with that because we'd already given them an initial bundle. Some complained of, a lot complained of poor mobile network coverage. So for those, especially those in the app group, sending their reports as at when due, very problematic because of the network. And then power supply was an issue. Many had dead phones at times. Next. We did not stratify our participants for maybe cancer type, the staging, and the performance score. And a lot of our patients were actually stage 3, stage 4, and of course, by the time we're reaching out to them much later, they had passed on. At the time this study was going on, we had some interruptions by local and nationwide industrial strike actions in the healthcare system. So that was a problem. And then, of course, there was a time when there was a stock out of oral liquid morphine. So that tended to cause the patients to have high pain scores, and which we think may have affected our studies. Next. So what did we learn of this? Even though we think that this kind of research is actually the first to explore the use of mobile health technology in palliative care in Nigeria, we think that mobile devices have a place in the management of palliative care patients, and that when we're doing studies like this, if there is anything we can do to reduce participants' burden or the caregiver burden, those are the things that are most successful in increasing study retention. As you can see, for the patients in the app group, we bought them mobile phones because we said to ourselves, if we don't do that, they probably not use the app. We bought them data. So that would account for why they were able to use the phone for some considerable length of time before the study ended. We also have learned that high retention rates can be achieved by adapting innovative culture and ethnic sensitive research retention methods, which are proven to be effective. And we also need to remember that these patients sometimes come with their caregivers, and the caregivers have huge burdens. So if we're able to while we're doing our research for patients in palliative care, we shouldn't forget the caregivers. Anything to reduce the caregiver burden will also help our patients to participate effectively in the research. Next slide. Thank you.
So thank you, Tanya. It's a very, very interesting study, and I think things will get better for you as the phone networks and so on improve. There are a couple of questions in the chat. So Mohammed Jallo asks, what would happen to the usual care group in case of a serious complication if they don't have a phone or an app? You're muted.
Oh, I'm sorry. Yes, you know, the usual care group is the group as we are, you know, which is they know that that if they have a problem, they come to they always come to the accident and emergency of the hospital, and then the accident and emergency team will reach us. So we expected that if they had a serious complication, they would do the usual, which is to go to the A&E of our hospital.
Okay.
Then this question says, how did I get the sample size? Yes, we had a statistician that had used, that we sat with, and we looked through studies that had been, similar studies that have been conducted in developed climes. It's actually one by, I can't remember her name, but in the UK. And so it was based on the, their own sample size and we calculated us and used it. Then it says, how did we select the participants? Were they still receiving treatment? Yes, these were patients who were already seeing the oncologist and were seeing us. So they were not first-time cancer patients. And if you recall, I said that part of the limitation of our research is that we did not stratify these patients for the stage of their cancers, for their performance scores. We didn't do all of that. So I guess those would be huge confounding factors in this research.
Yeah, one of my thoughts when you introduced this was that by asking people to respond twice a day is a huge burden for people. And I wonder if you did the study again, if you might, but if you decrease that, say, to twice a week plus any new problem, that you might get greater response because of less burden. And also you would have less using up of the data on your phone. So if you did this study again, or if you did a follow-up study, Tonya, what changes would you make?
Okay, yes, if I did a follow-up study, yeah, that is really, really, really very important. Reducing the frequency, because at a point, the nurses would report, I called them to find out why they didn't sending anything today. And they said, but there's nothing new to sending. Mm-hmm. So that's thank you for that. Another thing I think I will change would be maybe I've been thinking which is what our team is working at. We've been thinking about how can we get these reports from the patients without having them to rely so much on data. So that's something. So we've been looking at USSD, mm-hmm. because USSD can work outside of internet data. So those are some of the things we're looking at. And then the third thing is we looked at our limitations and we're like, who do we offer this to? Who's best to get this? Would it be patients in stage 1, stage 2 versus stage 3, stage 4? We're also looking at that as we're refining the app.
I think we better make this the last question. This is from Francine Kuya, and she's asking about, did you evaluate other causes of distress? For example, women who are abandoned by their spouses because of the disease.
We didn't have, yes, we actually explored for other issues, but we didn't have any female participants that had this kind of issue.
Good. Okay. Well, thank you for that. And I do encourage you to do further studies because I think there's a lot of potential in using mobile phones. I know that the coverage from mobile phones is improving in low and middle income countries. And so I think the potential there is for the future. But that's great, and carry on with your research. And if any of the people on the call today can help or advise you, we'll be happy to do it. Send us an email.
Thank you.
All right, so we're going to move on now to the presentations by guest faculty from the US. And I think Jean Kuttner is going to speak first. So go ahead, Jean.
Wonderful, thank you. And thank you, Dr. Onyeka, for that terrific presentation. And so our plan now is myself and my colleagues, Dr. Pollock and Dr. Bennett, will be running through some topics, kind of sort of key topics around palliative care research. And we specifically wanted to start the session with Dr. Onyeka going first, because we thought that hearing about a real world study would make the other topics that we're going to be talking about come alive. And I do think, Dr. Onyeka, that you covered everything that we're going to now cover in our presentation. So go ahead, next slide. And Why don't you go ahead to the one with the palliative care definition on it. So one more, two more. Whoop, one more. One more. One more. There we go. Um, this is probably review for everybody, but I just wanted, if we're talking about palliative care research, we wanted to make sure that everybody was working off of the same definition of what palliative care is. And we're definitely taking the really broad definition of palliative care. And for those of you who responded to the survey about your research topics, it does look like you all are thinking similarly in terms of a broad definition of palliative care, with this one being the World Health Organization definition of palliative care that is focused on improving quality of life. And we talked in the last session about, or Dr. Onyeka mentioned about caregivers. So both of the person who has the illness as well as their families that are facing a life-threatening illness, and focusing on that broad spectrum and use of issues that people with serious illness experience. And again, you saw that with Dr. Onyeka's work in terms of the measures that she picked and some of the discussion in the chat. Next slide, please. And the other key piece of the definition as we're thinking about it is thinking about palliative care being integrated with other health services and throughout the course and the spectrum and the time frame of a person's disease. And this gets at, which we'll get to that next, also around defining your patient population and where in the course of that disease. And I think Dr. Onyeka mentioned that in terms of defining your study population and where they are in that course of the illness trajectory, thank you, where somebody may interface with palliative care, which would then help us in defining our study populations. And this is just another way, people have probably seen this figure before, about the way that you have maybe waxing and waning over time, the extent to which palliative care is the focus of the attention and care that people are receiving. So go ahead next. And it was interesting in preparing for this talk, looking back at some prior talks and how far we've come in palliative care research. You saw from the WHO definition that there's a definitive statement from the WHO that palliative care does improve outcomes for patients and their families. And we've definitely seen really across the world that palliative care from a clinical perspective has continued to grow and expand, and there are more and more palliative care services available to help our patients. And those of us that have been doing this for a while, probably recall the days when we were basically practicing evidence-free medicine, and that we were extrapolating from other situations, other patient populations, to do the best that we could for care for patients. And there definitely is a better evidence base than when many of us started in this field, but there's still so many things that we see and do on a daily basis where we need evidence to support and define what is really best practices. So many topics to still be studied in palliative care. Go ahead. I did bring forward two references, and I included the references in the slides of some work that has been done in identifying palliative care research priorities. This is one that was published in the Journal of Pain and Symptom Management in 2014 that identified really three topic areas of priorities. One around the patients, their families, and volunteers, one around healthcare providers, and one around health systems, with these specific areas being being called out as on the prior slide and this one. And as you see, Dr. Onyeka's work fitting nicely in this in terms of a research priority on how that we really best deliver. If we know that palliative care is going to help people, how do we best deliver that to people? So I would direct you to this article as if you're looking at some nice work that's been done around identifying research priorities. Next slide, please. There's also a really nice review. This was published in BMC Palliative Care in, I guess that is last year now, 2020, and did a systematic review of palliative care research priorities internationally. And they nicely framed it in what we think about as a quality framework that many of us are familiar with, of structure, process, and outcomes. And thinking about where we focus our research questions in this sort of model, I thought was helpful. Am I looking at the service delivery model, or training and education, which is an important focus for palliative care research? Am I looking at the process of how that care is actually delivered to patients, or am I looking at patient outcomes themselves, and having this help frame both our research questions, and then, as Dr. Bennett will get to, also helping us frame how we pick our research, the measures that we use. So you may wonder if there's such an imperative, why are there still gaps in research? If I put aside the funding for research and just look at research design, since that's what we're focused on today, I think that Dr. Onyeka may have gotten at all of these, and I think Dr. Bennett will get at this as well, is that we have to decide what outcomes we're actually going to measure, because our patients that have serious illness have multiple things that we could measure, as well as they themselves are experiencing these physical symptoms, emotional issues, as well as other problems, which then makes it hard for people to actually, excuse me, participate in research. And as Dr. Onyeka mentioned, the real need to make sure that we're being very thoughtful about decreasing the burden on our study populations, as people are not going to sit, still for, 2-hour in-depth interviews, or, long study instruments. We also have to plan ahead for missing data for 2 reasons. One, our patients die, and 2, our patients may become too sick to actually respond or to provide data for our studies. There may be, and I know Dr. Bennett will get into this, there are some outcomes that are easier to study than others. So sort of joke, mortality is probably the easiest outcome to measure, and even then it can be hard to capture. And then you get at, some of the topics that were brought up in the chat. How do you measure distress? And are we really capturing that? Some of these outcomes are quite I think are more difficult to study than what maybe some of our colleagues that maybe study the effects of a blood pressure medication, where, blood pressure is relatively easy to study. And then we also need to design our studies to be able to follow patients across multiple care settings, if they're in a hospital, if they're in a clinic, or if they're at home, or in another setting, making sure that we've designed our studies to be able to follow those patients and understand what's happening in each of those care settings. The gatekeeping is one that is important for how we design our study recruitment. I think we've all had multiple experiences where, if we rely on, say, physicians like myself to refer patients to a study, often we don't get very many patients referred, because we think we're trying to protect our patients. And then lastly, we think about traditional randomized clinical trial study designs, because of the complexities of this population and their outcomes, that we often have to be thinking about more innovative study designs, which then we then need to find methodologists and statisticians that can help us with that. So my job was to kind of set the stage, following up on Dr. Onyeka, and I will now hand off to Dr. Pollock, or I guess should I pause for questions first before I hand off?
It's up to you, but we could take the discussion at the end. I don't see any more particular questions in the chat.
So maybe do that, but maybe we go. Maybe we do our three, and then because I think questions probably are going to
come together at the end.
Yeah. Okay.
Why don't we go on to Catherine's talk?
Dr. Pollock.
Yes, thank you so much. I really appreciate the opportunity to speak with you. And I wish I spoke French and could speak more clearly, but I will try to speak slowly. So I really have appreciated both talks, setting the stage for what is somewhat novel way of doing research in the United States, which is to do community engaged research. And so what I want to talk to you about today is stakeholder engagement in study design, conduct, interpretation, and dissemination. I have no conflicts to disclose. So this is the first question. I love, Dr. Onyeka, one of your first slides was you laid out what the problems are, and you didn't come up with those problems yourself. And you'll see one of the questions we asked you in the survey before this talk is what population are you interested in? So that's really the first question. If you're thinking about, I want to do research in palliative care, who are you most passionate about helping? And once you figured out who that population is, it could be patients with cancer, it could be patients with dementia, it could be caregivers like we've been talking about a lot. Once you figure out what population you're passionate about, and the reason that passion is important is because research is really fun and it's really hard. And we want you to pick something that's really fun and that you care about, because then the hard work isn't as hard. But once you figure out what the population is, then you need to find a partner. And the whole thrust of my talk is that the way that we used to do research is we researchers would sit in our offices and think of questions we think were important based on the research, and then devise studies and programs for people without talking to the people at all with whom we were trying to help. And what we've learned, and so there are two problems with that. One, you may design a study that the people don't want at all. That's one problem. The second problem is you may design a study that does work well, but then it's not sustainable because you haven't worked with your community and your community partner to come up with something that after you're done can keep going. And so, but the very first thing you should do, and that's why I loved Dr. Onyeka's one of her first slides, is go to the community and ask them, what are the problems? We often think we know what's wrong and what needs to be solved, but what we think is wrong and needs to be solved may not be important to the community at all. And so if we go in with what we think is wrong and needs to be solved, the community may reject our program because it's not important to them. And so the best thing to do is, this is the population I want to work with. I need to listen to them and find out what it is they need, what it is that they need to be solved. I have the research expertise that I can bring to them, but I need to partner with them so that I am definitely addressing something that they care about. Next slide, please. So what's the problem? Well, what do they think is the problem? Now, it is important that you still bring your expertise, because you're going to use the literature to tell you what the evidence-based methods are. Now, some of those evidence-based methods may not fit for the problem you're trying to solve, so you need to innovate. The cool thing about doing community engaged research is that the stakeholders themselves, the community partners themselves, help brainstorm the solution. And that has the greatest chance of success, better than something that you come up with by yourself in your office. You go and you talk to them and you say, okay, now you've told me what the problem is. Let's figure out a way to solve this. Now they may can't come up with solutions that actually you don't think will work because there have been studies that have done that already and they don't work. And so then you partner with them to say, well, that's a good idea. I also know that if we do it this way, it might have a greater impact because you have the literature behind you supporting a certain way. Because there are theories of behavior change and research that help drive effective programs. But before you make your suggestions, let your partner voice his or their opinions first, and then you come in after. Because often what happens is if we come in and we say, oh, great, I hear what your problem is. We should do this, 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 and this. The community may not feel like they can say, oh, Dr. Onyeka, I think that's a bad idea. They might just go along with what you're saying, even if it doesn't work. So you really want to hold back your ideas and let them come up with the ideas first, and then you can partner together. So the order of that is really important to make sure that their voice is heard. Thank you. Next slide, please. So now you know what the problem is, you know what some potential solutions are, but then how do you do it? And so with your partner, you co-develop the program. And that is really, really fun. Like, what's the best way to reach the people? What's the best way to recruit people? I love that there were some recruitment questions in Dr. Onyeka's slide. Like, how did you get those people? Because you know who knows how to recruit the patients? The community knows how. You talk to them about the best ways to do it. And also just that formative work, working with the community members can help you come up with a program that is going to be acceptable, feasible, and hopefully sustainable. Next slide, please. So then you get to test the program. That's where your study design comes in. And with your partner, you recruit the participants. In the United States, we have problems with trust. Some participants in some communities don't trust research. I imagine that is true in some of your communities as well. So when researchers come in and say, oh, you need to be in this study, people are nervous. And so having community partners help you in build that trust and say, no, I'm partnering with Dr. So-and-so. You can trust her. This is a good study. So having the community involved will help you recruit participants also. But also be aware of what study designs work well in some communities versus others. Some communities may not like our standard randomized controlled trial. They don't like the fact that some people get the treatment and some people don't. Because then they say, well, how come I don't get the treatment? They don't understand random assignment. They don't understand that. They might feel like it's unfair. And so really working with the community to find a study design that still can answer your research question, but is acceptable to the community. Next slide, please. So then you get to analyze the data. You get your data back from your really cool program that you co-developed with your community partner. Work with your partners to look at the data. They will help you interpret what this means and what this means, because that's the fun part. Once you get your data, for me as a researcher, that's the most fun part, is what does this data mean? Well, again, if we're sitting in our offices by ourselves trying to figure out what the data means, we're not going to have as good an understanding as if we work with our community partners and they can say, oh, they're doing this because of this. Oh, I didn't even know that, because you have a better understanding of the community than I. And so it's really fun to have them as partners in that stage of the research as well. Next, please. And then finally, and a very important part, is disseminate your findings. Many times we do research and we never tell the people with whom we are with whom we are studying what we found. And so that can make them feel like they've been tested or been like what we call a guinea pig or an experimental rat. It is much better you do the study and then you go back to the community and you say, hey, community members, this is what I found. It shows transparency, it will build trust, and the community, your community partners can help you do that. They also will help you when you can say, wow, this part of the program worked really well and this part didn't at all. They can say, oh, you know why that didn't work? It didn't work because, like I love the example, because I didn't have enough power to charge my phone, or I didn't have any connectivity. So let's brainstorm ways to get around that, because I think this mobile app was really cool. We have a couple stumbling blocks, but let the community help you come up with the solutions. and thinking about how you will implement it on a broader scale. That is something that is relatively new in the United States that we are really pushing towards. Right when we're developing a program, we have an eye towards how are we going to implement this if we find out that it's successful. And even though that sounds silly that we're just thinking about that, it is really a pretty new idea for us because we develop these programs that we never implement. So it doesn't really do any good if we find a program that works and we never get it to the people. So the community can help you with that as well. Next slide, please. And then finally, try to implement it. Implementation is messy, it's fun, and the community can help you do that. And what's, like I was alluding to before, sustainability is key because for the community to keep working with you, they need to know that you have their best interests in heart and not just your research question. So whatever you're developing, have an eye towards sustaining that program even after you're gone so that they feel like you are making the community a better place as opposed to a worse place when you're done. Next, please. And that might be it. Yep, that is it. And I think I saw a question popping up, but I didn't have a chance. Is testing the program equivalent to doing a pilot study? That is a great question, Komba. I recommend before you try to do any program on a large scale that you do a tiny pilot study to see if it's feasible and if the people like it. So often what I do is I do a pilot study with maybe 30-ish people, 15 in each group if I'm doing a 2-arm. And my main outcomes are feasibility. Is it even feasible to deliver this intervention? Acceptability. Do people like it? And a signal for efficacy. Like, are things going in the right direction? I'm not going to have the power to detect if it's really having an impact, but I want to make sure that the numbers are going in the right direction as opposed to the wrong direction. And so I really love the idea of doing a pilot before you do a large study. And if there are other questions, oh, I appreciate that. Speaking of recognizing the needs, yes, thank you for putting that link, Kuomba, about cervical cancer screening. Great, or cervical cancer suffering, excuse me. All right, if there aren't other questions, I'm happy to be part of the panel once Antonio is done with her talk. Thank you so much for your attention.
Why don't we do that? And as Antonia, I'm sorry, is giving her talk, why don't you think of questions that you would like to ask and put them in the chat. Pour les gens qui parlent français, pensez des questions que vous désirez poser et à la fin, on aura l'occasion pour les réponses aux questions. Vous pourriez les poser en français et je peux traduire s'il faut, mais à la fin de la prochaine présentation. So Antonia, please go ahead and talk to us about measurement tools.
Terrific. Bonjour, je suis heureuse de parler avec vous aujourd'hui. Today, I will discuss measurement tools for palliative care research. And you may hear a little bit of noise in the background. There are some repairs happening right now, but I hope they will be taking a lunch break soon. Okay. I have no potential conflicts of interest. Patient-reported outcome questionnaires assess topics a patient can report about their own health, such as symptoms, physical function, mental health, and quality of life. And here is an example of 3 questions from a patient-reported outcome instrument about physical function. So you can see that there are a couple of questions and the patient is asked to choose an answer from the multiple choice answers. Next slide. It is important to design your research study in order. First, you specify the research question. Then you specify the study endpoints. And once you have specified the study endpoints, then you can identify the best measurement tools for your study. Next slide, please. This slide shows the 6 major steps to designing an intervention trial. Again, it is important to start at the beginning with step 1 and then proceed in order. Specifying the measurement instruments is in step 5. And I encourage you to look at this when you are designing your own studies. Next slide, please. When you specify the endpoints for your study, remember that an intervention will have a greater effect on proximal outcomes than on distal outcomes. For example, a drug that improves nausea may improve quality of life. The proximal outcome is nausea, and the distal outcome is quality of life. Many other things can impact the distal outcome. It's also important, as Dr. Pollock was discussing, that the outcome should be important to stakeholders. Next slide, please. After you have specified the study outcomes, then you can identify the instruments for measuring those outcomes. When you are selecting patient-reported outcome instruments, look carefully at the questions in the instrument. Is this what you want to measure in your study? Here are 2 examples of instruments for measuring pain. This pain instrument measures the severity of pain and how pain interferes with daily life. Next slide, please. This pain instrument measures how the pain feels. It focuses on the sensations of pain. These 2 instruments that both measure pain are very different. So if you just looked at the title of the instrument, you might think that they are the same, but they're actually quite different. Next slide, please. There are a couple of measurement properties that you can read about in textbooks about measurement. Validity is whether the questionnaire measures what it is intended to measure. Reliability is, does the questionnaire produce the same outcome when it's completed repeatedly? And there's also the issue of sensitivity and responsiveness. Does the questionnaire detect differences between patients or within patients over time? I encourage you to use instruments that have good measurement properties so that because those instruments will be able to detect the change that's occurring that results from your intervention. In the remaining time I have, I'd like to tell you about the PCRC instrument library. It has information about 200 instruments that are useful in palliative care research. Next slide, please. These instruments have good measurement properties like validity and reliability. And the library contains information about each instrument, such as the content, the number of questions, and key citations or scientific papers about the instruments. The library is contained in an Excel spreadsheet. And you can request a copy of the library by going to this webpage and completing a brief online request form, and the library will be emailed to you right away. I'd also like to tell you, because this is ASCO, and this is a lot of this is focused on oncology. These are patient-reported outcome instruments that are used in oncology research. These instruments measure symptoms, function, and quality of life, and many of them are available in French. I will talk about one of them right now. This is information about the EORTC Quality of Life Questionnaire. Here is a link at the top to the web page that has a lot of information about the instrument. There is a core questionnaire. It's the QLQ-C30. It measures symptoms and function for cancer patients. And there are additional modules for each type of cancer. The modules include symptoms and problems that are specific to that type of cancer. Many of the PROs in oncology are organized like this. And so I've included information about them in the last 5 slides. You can review these when you have time. And so I'll end my talk there. Thank you very much.
So thank you. We're on good time, and thank you for, sorry, I didn't put on my video. Thank you for keeping to time. And now we have some time for questions and panel discussions. So we can start with the chat.